Hello, everyone. Welcome to the Couple Nurses podcast with your hosts, Peter Findera and myself, Matt Solarchik. This is a podcast where we tackle current health news and hot nursing topics, one conversation at a time. Thank you guys for tuning in. We know that we cannot give you back your time and attention, so we are grateful for that wherever you are listening. And if you find any value in this podcast, please give us a five-star comment, review, like, share with your family member. We really appreciate it. That's how we grow. That's how the algorithm picks us up, and it motivates us to keep on producing high-quality content. So thank you. How you doing, Pete?
I'm doing great, dude. I feel like you might get a little bit of negative stars coming in with our last controversial post, but New Year's coming along, so I think this was a perfect time to touch base upon the top 5 most paying nursing careers as we approach the new year, or if you guys are listening in the new year, who does not want a little bit more money, right? And as nurses, we do want some more money, and these are the top 5 most paid nursing careers. So top 5 are going to be registered nurse anesthetist, then we have a general nurse practitioner, following clinical nurse specialist, psychiatric nurse practitioner, and a certified nurse midwife.
So yeah, we're going to give you guys like a little breakdown of each, and we didn't write the actual income and salary of how much every career has because it's going to vary from state. Like, in Illinois, a nurse could make like let's just say 60, 70K, but here in California, a nurse is making 90 to 100K with the same degree. So we're not going to include any salaries. If you're curious in a career, you could just go look it up yourself per state and see how much they actually make.
Yeah, but overall, these are the top 5 ones. So let's hop into a certified nurse anesthetist. That's like almost every ICU nurse's goal, right?
Hell yeah.
The majority of ICU nurses, they do a year or 2 of ICU experience just to be able to qualify to go into school to be a nurse anesthetist. And these people are basically put you down for surgery, right? So it's not anesthesia, or she's not an anesthesiologist. They work under them. So it's kind of like an NP compared to a physician.
Yeah,
right?
it's basically having a doctor under you. Yeah. I actually shadowed one. I don't know if I told you that before, in LaGrange. So they work the same way where there's one anesthesiologist and there's going to be 4 CRNAs. The anesthesiologist has to come in at the beginning of the case, make sure that the CRNA sedated the patient properly and did the right steps, and then he'll go into another room, let that CRNA sedate and all that. Right. So he's just kind of around supervising and asking, whatever the CRNA needs, he'll be there and ask.
Yeah, kind of like if you do surgery, you have the main surgeon and you have the surgical residents, right? Yes. The surgical residents are doing these surgeries, and then the main surgeon, he just pops in from room to room to make sure everything's going or to help out in certain cases. And yeah, it's pretty cool. Like I know a few of my friends back in my old unit basically did ICU just so they could get to the CRNA school, right? CRNA school, I believe, is like 2 extra years, 2 to 3 extra years.
Yes.
On how you do it and how you block it off, because a lot of times a lot of nurses, they go to school and they work full time, right? So they go to school part time for the most part. So it might take a little bit longer, which is okay. But if you want to do a CRNA school, the main thing you have to do is get the ICU experience.
Yeah, and with CRNA, you usually can't work. Like, that's what people say. Maybe you could pull off part-time like we did while we were in nursing school. Most people, they commit full-time, and it takes about like 3 to 4 years, I believe, because it's a DNP. A lot of, they're stepping away from the master's program. You could do it in a different state. Illinois, for example, like Rush, like you have to get a DNP, which is close to 3 to 4 years. And it's about 100K of school, man. Right. So that's what kind of pushed me away, is I got to be 100K in loans, and then I got to miss like 3 years of being a full-time nurse. That's 210,000. Now we're looking at over 300K in debt when I get out of school, not including interest, and I got to pay it off. So me personally, I loved the route. I just don't want to commit back to school right now at this point in life.
Yeah, I feel. And if you guys do want to go back to school, like you could always ask your facility or people that you work for how much they're going to reimburse you. A lot of times, these hospitals, especially university hospitals, they're willing to pay majority, if not all, your tuition if you're going to work in their hospital for an X amount of years, right? So they'll tell you, hey, we'll cover you like 85% of school, but once you graduate, guess what? You're going to be working with us for the next 3 to 4 years. So, if you really like where you work and you really don't want to expand or go anywhere else, that's a great idea, because you're saving on tuition costs, and guess what? You're going to work in your basically dream job at your dream hospital.
Yep.
Yep. I know now it's about the DNP stuff. So currently right now you can still get a master's in nursing and still qualify to be a CRNA, but I think in like 2023 or 2024 they're completely eliminating that.
Okay.
So after I think 2023 or something like one of those years, look it up, don't quote me on this one, look it up yourself, but after that year you're going to have to get a DNP. So if you really want to be a CRNA without the whole DNP route, now is probably the best time to go. It might be like your only chance at it without doing the whole DNP.
Damn.
So what makes a good CRNA? So what makes a good CRNA is a person that likes critical thinking, that likes thinking outside the box, obviously likes numbers and quick on action, but also calm. Because, if you're sedating somebody, everyone might react a little differently. Some people might need more sedation, some people might need a little bit less, right? And if you don't have somebody sedated properly, and guess what, he's in an OR, you got to sedate them quickly. Like, that patient might not be physically freaking out, but you can tell by their vitals.
Yeah.
Like, if you're trying to put somebody like down with sedation and, they're getting cut open and their heart rate's going up, that's probably a bad sign, right? Common sense thinking like that. Well, not only common sense thinking like that, but critical thinking like that. Like, hey, we get that heart rate down, they're probably not sedated as much.
And it's a fine balance beam because you're literally being an artist with anesthesia, and you're sedating the patient, but now that the BP is liable, now you got to give some epinephrine and raise that up a little bit. So it's cool because you're just doing hardcore meds, and it's your responsibility when the surgeon is cutting the person open to make sure they're sedated and to properly extubate them post.
And this is why it's favorable for ICU nurses, because as ICU nurses, we want control, right, over our patients, everything, over our vitals, over what we give, everything like that. And this is perfect for my ICU nurse going to CRNA, because as a CNR, you have a lot more control than a nurse, right? You are basically setting up your own orders, right? Like, as nurses, we can't set up our own orders. We can't give certain medications because you don't have the order. As a CRNA, guess what? You have the right to give all those medications. It's your choice on which meds to give, which is very cool.
Hell yeah.
You basically make your own cocktail on how to sedate somebody.
Yep.
And you kind of, each CRNA might have a different way to sedate somebody than somebody else. It's really cool.
Just like in the ICU, everybody has a different way of doing things, and you are accomplishing the same goal. So the second one is General Nurse Practitioner, and that's basically working under the family doctor. So you're going to be able to have extra perks compared to a BSN and MSN nurse, right? You're going to be able to prescribe. You're going to be able to give medications, potentially diagnose illnesses, and you could recommend alternative treatment plans. With that, it just comes a lot more responsibility because you are transitioning from a nurse that takes orders from doctors, and it's, you basically present the problem to a doctor and they have to fix it and they give you orders. Here, you are the person that the problem is going to be put upon. So you have to make that decision of what the treatment plan is, what the treatment goal is.
Yeah, and when I see my physician, majority of the time is spent with his nurse practitioner. She basically does almost all the charting. She does all the recording. She asks me all the questions. Don't get me wrong, the doctor does a good job too, but the majority of the conversation, majority of the work is done by the nurse practitioner. So I'm not gonna say it's like an assistant to the doctor, but she basically fills the doctor's role, and doctor is like he's been more of a leadership position at that point, where he just kind of, like, same way the anesthesiologist rounds on the CRNAs, this is kind of like the doctor rounds on the NPs, but he also runs on the patient too.
Yeah.
Because he's got to get a picture of what's going on as well.
And a perfect example is like an orthopedic. So when I worked in orthopedics as a med surg nurse for a year, the surgeon did the surgery correct. He did, like, just say total knee, total hip. The first day, he usually consults, right? Does all that. Then the next couple of days, when the patient's getting better, the NP is going to make the rounds. They're going to see how the patient is doing, what kind of maybe equipment they need, what kind of prescriptions they need to be sent home with, maybe the polar device, the cooling, device for the hips and the knees. And usually the doctor will not see them anymore, maybe till there's a follow-up, scheduled when they get out of the hospital. So it's like, why should a doctor do all these surgeries and see all their patients when they could decrease the workload and technically make more money by seeing more patients and just paying the NP less, and you're able to maximize your workload technically. Right. And that's what the nurse practitioner technically is there for the doctor.
Yeah. So nurse practitioner makes the physician's life more efficient.
Yes.
Than the surgeon life. So how do you become an NP? I mean, it's a pretty simple route. It's probably one of the more common routes for overall nurses to go in compared to the CRNA. So you're obviously going to need your bachelor's in nursing. Then you're going to get the master's. And some schools do offer an option to also go the DNP route when you want to progress at school. So some schools are going to require doctorate, but not all nurse practitioners are going to need the doctorate degree to be a nurse practitioner. And there's different routes you go with nurse practitioner. Like I mentioned, there's a general one, and you can work more acute setting. You can work more with geriatrics. A lot of specialties you could go into.
Yeah, you could be family practice where you're just working at a clinic, maybe a small doctor's office. I know dermatologists even have them. That's probably a little bit more laid back job. And you could go all the way to like acute care. You could literally be working underneath the intensivists when it's nighttime, you're going to be taking calls from the nurses and seeing what the ICU patient needs when something's happening. Maybe you have to come in and start a line. I know in one hospital, I think they had to start like 15 central lines with the doctor till they could perform their own central line insertions. So it all depends, but it's just like nursing. It's a broad specialty that you could do a lot of different things and that you might like and not like, and choose whatever you like.
Right. Yeah, it's cool because if you're a nurse that selects the acute care, you could be like an acute care nurse practitioner, and like Matt said, you could put in lines like, yeah, you're probably gonna be on call overnight when you're starting off, and then you can transition to days.
It just it depends on how much you like bedside, you know.
You want to do, yeah.
Like if you're tired from bedside, or you're tired from wiping butts and doing all these little things and answering call lights, and you want to look, you want to come in with some freaking nice pants and some dress shoes on. I mean, that's the route that you could take. You could transition away from bedside.
Yeah, it's less direct patient care and more like emergent situations.
Yes.
Right, and of course they do come and assess and everything. Like if admission could come in, they would assess the patient, put eyes on him, see how he's doing, things like that. So it's a cool route to go to. I thought about becoming an NP, but leaning towards away from it. Maybe I'll readdress it in the future.
Yeah, and there's still no price point for what you're doing. You're still selfless in this field, no matter what you do and what specialty you pick. You're still doing your part.
Yeah. And number 3 for you guys, we have clinical nurse specialist. So this is kind of the one career where I wasn't sure what it actually means. Let me just go over what they actually do. So they manage the care of complex and vulnerable populations. They educate and support interprofessional staff to provide optimal care through the use of evidence-based research, and they facilitate a culture of safety within healthcare systems. So they're kind of like in between. So they're like, it's hard to explain because it's kind of like
in
a very
between a
broad,
manager and a nurse in a way,
Yeah, almost like that, but it's not really like an assistant manager. Yeah, they're there, part of the interdisciplinary team to make sure that the latest research is being done, basically, that everything is handled in the correct manner, that the patient is getting the appropriate care. And if like a problem arises, like how, let's say the numbers for your patient care are decreased, you have poor patient care numbers. So it's kind of their job to figure out what can we do to facilitate more patient care, better patient nurse interactions. Yes. So they kind of follow the research and see where we can improve and how to improve on it.
And they also advocate for the nurses, correct?
They do.
I'm correct. So they're able to like implement quicker ways or more effective ways, evidence-based ways to do the same job.
Yeah. Like let's say there's been an issue with Dobhoffs. One certain brand of Dobhoffs is for some reason it's coiling, in the throat, or it's getting placed in the lungs more often than before. Maybe they have to do some research and get some different Dobhoffs, and she's gonna be kind of in charge of that. Maybe they need something that's more firm or something, and she's gonna advise that, hey, research shows that Dobhoff made by this company has shown to reduce the risk of pneumos compared to this company. So she's going to advocate for that to make sure that the patient is safe and that the nurse is safe, things like that. It's pretty cool.
So she's going to be facilitating that. It also sounds like if, let's just say the hospital needs to cut the budget, that's probably a profession that might get cut first, and to be careful for that. It seems like it's an important job, but when the hospital is going to need to make some money, I feel like they're going to cut those positions first. So just be very aware of that.
Yeah, it's one of those good paying low-key jobs that people don't really know about and don't really hear about. But with that comes, there's the first ones to get cut. We're not saying don't go this route. We're just saying, you might have a little bit of issue with security if times get tough in the hospital environment. So you might want to go, if you want to be one of these, you might want to go to like a more known hospital where their financials are properly placed. Because this does improve patient outcomes and nursing satisfaction, but also costs money. So not every hospital is going to have that money to devote to these kind of people.
And if you look at the perspective of what's happening right now in the hospitals, and they're overfilled, they're stressed out, like they're not looking at meticulous charting or trying to expand all these jobs, or like we're just trying to get by in a hospital setting right now. That's what's happening. Yeah. So this job is not as important. You know what I mean? Like it's
important, that's not as secure.
Exactly. Like we're just giving you guys like the real life examples, like the hard truth of like what's up, kind of, and like some people don't like to hear it, and that's why we always have to kind of like cover our asses just to like prevent any sensitive people from overreacting to this. Like we're just telling you how it is. Lay down the law. So after clinical nurse specialist here, we're going to go into number 4, which is a psychiatric nurse practitioner. And if you're wondering, that's more the mental health route. So if you're into mental health and all that, that might be a profession for you. So you're basically taking care of patients that have different psychiatric disorders. You're going to be a psychiatric NP, and you're going to be able to manage these patients with these illnesses, disorders, And it could be anything from anxiety, it could be from ADHD, mood disorders, substance abuses, and maybe more serious patients like schizo or suicide.
I feel like this is going to be right now, like psychiatric nurse practitioner. You don't really hear that too often. Like I didn't think it was gonna make the list until I saw it. I was like, damn, psychiatric nurse practitioner make solid money. Like I didn't know that. And if you look at it, like I feel like the trend of like the world is going towards more mental health.
Yes.
Right. Everyone's into more wellness, mindfulness, holistic care, things like that. We're taking, instead of a system based approach, looks like we're trying to come up with like a holistic approach, right? You know, mind is basically an organ as well. So this is something that's probably going to be on a rise in the future. Definitely, probably in 2021, especially with C-19 now.
Post lockdown.
Imagine how many people are going to suffer for different mental health issues, right? Because a lot of times, what triggers like a mental health event is like a stressful event, right? Some kind of, you're placed in a stressful environment, and that gene flips on, and then you're diagnosed with like a psychiatric illness. This doesn't happen overnight,
Yeah.
right? So there's some kind of a cause from it, right? And I feel like C-19 is going to cause a lot of those issues, and you know, as a psychiatric nurse, you could be there to help out those people.
Yep.
Yeah, and it's really cool. It's really rewarding. I was never big into psychiatric health. I just didn't like. I don't know. It was hard for me. Like clinical was hard for me. Like it was hard for me to get through some of these people.
So yeah, like I did a clinical with like teenagers, and it was really rough for me because I just didn't get the same job satisfaction from like helping and healing. This is me personally, of course, because I felt like when I talk to these like teenagers, like I'm like, whoa, man, their brains are like, they have a different way of living and thinking. And I'm just like, how do I help those kind of people? Like that was very hard for me to do. Like when I sat down for a one-on-one interview and like I asked these questions, and I forgot what the kid was doing. Like he threatened to kill his his sister with like a knife, and he just was saying weird stuff. He like tried to cut off the balls out of a freaking damn cat or something. Like he tried to like neuter the damn cat. Like it was just really mentally weird.
Yeah.
Like how can I help that person?
Yeah.
And that bothered me to the point I'm just like, I don't think that's the career for me, because I'm not going to get that same satisfaction and when I help like a patient like bedside in the ICU personally.
Exact same thing. And like my clinic was the same. People were saying these like out of the box things that like you wouldn't be able to even think about.
Yeah, it's hard to comprehend.
Yeah, and it was hard for me to kind of put myself in like their shoes and try to help them out because I just didn't know how to. And that was like the hardest thing for me. That's kind of why I started away from psychiatric nursing, because like I wanted to help them. I wish I could. I just couldn't. I just didn't know how. So it just takes like a special kind of nurse to deal with these. Like you get some respect. Like you gotta give nurses some respect. Like they could hear this stuff day in, day out, and they know how to talk back to them, to calm them down, to kind of put them back into reality, and like they know how to calm people down and how to treat them. Like I have no idea, man. Like I don't even know where to begin.
Yeah. Shout out to anybody that's working in psychiatric department or is interested in working there. And I wish there was somebody listening that maybe is in psychiatrics. Hit us up. We would love to have you on the show to even like talk about this stuff.
That'll be super interesting.
Yeah, because it's like the ICU, right? It takes a special nurse to do it. Sometimes we just deal with very damn sick people, and I think that's what we talked about recently. Correct? It's just like right now in the ICU, like everybody's vented. Like I miss a good conversation with somebody, with like a sick person, because we don't have that anymore. Everybody has a damn breathing tube, and there's no communication. It's just me doing my task and taking care of this person alive. And it's just a hard time that's happening right now in the ICU.
Yeah. It's interesting because ICU sometimes it goes both ways. Like you have those times where you're just like, you have a patient that's 8 times 4, and I don't want to say that they're annoying, but they're really needy, and you're just like, dude, I wish I just had my sedation.
The alcohol withdrawal ones.
Yeah, alcohol withdrawal. I wish I had just my sedated and vented patients. Those are so much easier to deal with, but they're really not easy to deal with, But it's crazy how it goes both ways. There's
It's good
days,
to have a change of pace.
right? Yeah, we like a nice change of pace. Like there's times where I wouldn't mind conversing with somebody. I have some time, but I can't because they're sedated. It's also cool to kind of learn their perspective and ask them different questions and see how they think about things.
Yeah, or just picking the brain of an older person.
Exactly, yeah, because they're older, so they have that much more experience. Like talking to somebody that's like 67 years old, they know a vast more than I do. It's always interesting to ask where they come from, what they did for a living, because that also impacts their like opinions too. It's so cool, but that can't always happen in ICU.
That's how you learn too. Like you just listen to these old people, like they're just full of wisdom, and sometimes their life is different from yours, but you're able to learn something from their life and apply it to yours. And I think that's what's so beautiful about taking care of the older population. Those, of course, that are very aware and have done something, because you also have because we're in the ICU, we deal with very sick people. There's also those sick people that didn't really do anything. They always kind of like hated life. They're, like let's just say alcohol abuse. And it's just like, it's hard to have a conversation because they haven't conquered themselves yet. They're still drowning in this addiction or whatever the case might be.
Yeah, exactly. All right, guys. So number 5 is going to be a certified nurse midwife. This is the perfect ideal career for anybody that loves labor and delivery, because this is going to be you basically delivering babies all day, every day. And the requirements for this is basically a master's degree in, or master's degree program in nurse midwifery, right? And then you got to pass an exam and you become a nurse midwife. You, of course, work under a physician or under an NP, but your role is basically going to take part in like the prenatal care, the postnatal care. You're there during the whole birth process, a little bit before and a little bit after. You're kind of there with the mom through her whole labor. It's actually really cool if you're really into it. Not my thing, and I mean might be Matt's thing, but delivering babies was never my thing. It's cool.
Yeah.
I didn't deliver any babies. Like I know some nurses got to deliver babies, or they were not physically, but they were there during the delivery phase. But for me, for my clinical, it was a little unfortunate because I worked in a primarily Middle Eastern cultured hospital. So a lot of times women didn't want me in the room during labor, which I completely understand, which is okay. There was a few instances where my teacher was able to sneak me in the bag, told me to wear like a mask and a hairnet, so it would be hard to tell that I'm a dude. If you go and see the eyes, it's kind of hard to tell. And plus, they're in labor, so they might not pay attention. So I saw a few of those, maybe like 2 or 3 labors.
I unfortunately did not see any C-sections or births. Man.
Really, I literally saw C-sections every day. I was basically going to the OR for C-sections.
Pretty gnarly, huh?
Yeah, it's pretty cool because those women were kind of tend to be less Middle Eastern, and there tends to be more open on who could see it, and they also weren't really able to see who was in the room because they had that like the gown in front of them. So I was able to, I don't want to say sneak in there more easily, but I was able to kind of see more C-sections because of that.
Yeah. Well, the only time, I mean, L&D is not my thing, of course, too. I had a little baby that I was trying to change that was just recently born that like pooped first and then started peeing towards me, like almost peed on my damn scrubs. And it's just funny because it was just, not the wife, geez. The mother of the baby was just like cracking up about it. But that was like my little experience. I seen quick circumcision when I was in L&D.
Yeah, I saw it too.
I was like, ooh, that's freaking rough, man.
Yeah, they're like different kinds. For mine, not for mine personally, but the one that I saw, they put like a little cone over like the head of the penis and then just like snip it off.
Yeah, man.
That's some shit.
It's like a quick little blade, right?
Yeah, dude, it's crazy. But I like being a nursery though. That was fun. Like wrapping the burritos and or wrapping the kids in like a little burrito. Like
nursery?
Yeah, nursery was always so fun, dude. I always used to go there. Like if it was like slow and like the OR, I was always go to nursery and just like change babies all day. It was probably like one of the funnest clinicals I've ever did.
It's cool because there's different section in this like L&D, if I'm remembering correct. There was like a special section where the baby was getting like the special blue light. Is that what that is?
I'm not sure if it's blue light, but like it's like heated, warmed.
Yeah,
like
warmed, and it was some kind of light to, I think, get rid of the brown fat. This is how much we know about L&D. We're like trying to literally think about this right now because I have no idea.
For our clinicals like 5 years ago.
Yeah, I'm trying to remember. Like L&D, OB-GYN, like that's like my least favorite subject in nursing school, and to this day, I just don't have no interest in it.
Yeah, I feel that's how it is. I mean, we're dudes, so like naturally, genetically, we're gonna be more wanting of a different side of it, because not a lot of guys want to see women give birth all the time. That's totally a female thing, right?
Yeah.
Same way like majority of females don't want to give people prostate exams, right? Because it's like a dude thing, right? It's kind of how it makes sense. Same way when you go get your prostate check, you're more prone to seeing a male doctor, right? This is how life works sometimes.
I wonder how, because of what during this time, I wonder if that changed at all. Like, is there any more men in that field, or are they more accepted? I don't know, but I don't know.
I don't think so, to be honest. No. Like, because if you see majority of male nurses, they're in more of like the critical care setting, or like
there's a lot of dudes in the ICU for sure.
Yeah, you don't really see them more on women's health, because like same with like the psychiatric nursing, it's a lot harder for us to paint that picture or put ourselves in their spot, right? Because no matter how much books you read about labor, no matter how much deliveries you do, you still can't resonate on that level, because you're never going to be able to bear a baby, at least for now. Maybe 10 years down the line, Matt might want to put a baby in his stomach and change all that shit up, the anatomy, but you never know. As of now, we can only relate to a certain level. Yeah. And past that, it's unknown.
It's unknown.
Yeah. Same way,
there's no
like,
experience.
you can explain to a woman how much it hurts when you sit on your balls, right? By accident, you sit on your balls.
Or when you got
before.
tapped by
Yeah, or you get
accident.
tapped. Yeah, or you wake up, and like take a nap at work and you wake up with a boner by accident. Like it happens. Like it's only so much you could explain it, but you're not gonna know how it feels.
Right.
It's just how it is.
Just part of being a guy, guys. Just understand that it sucks sometimes, just like females. When it comes to the duties that a midwife might perform, so she might be educating the woman on birth options, or like how you might plan the birth. You might be doing fetal monitoring, maternal health. You might be treating conditions that arise with pregnancy, such as like gestational diabetes. You might be doing some like low performing interventions, such as like actually delivering the baby or relieving pain during labor. I think there's a technique they press on the spine. There's so much stuff, and you might be prescribing and doing physical exams. So it's a cool profession. It's like an NP, but basically it's an OB-GYN setting, if that's what you're for. And to summarize these 5, maybe you just like bedside. Maybe you just want to be a BSN nurse, and that's totally okay too. Like there's money to be made there as well from picking up shifts or working peer DM.
Yeah, or you don't want to do something completely outside of nursing, right? Like look at Kat Golden. She did a whole movement, like
Nurses by nurses.
right? And we're doing podcasting. So if you like me and Matt, we enjoy nursing, but do we enjoy other things as well that's not nursing? Yeah, that's completely fine. These are just the top 5 paying nursing careers that people might be into. But if you want to do something outside of nursing, we highly encourage that because it's very rewarding as well. And a lot of people don't understand how much benefit nursing knowledge brings to other things like entrepreneurship, like business, accounting, things like that, because you have a very rare perspective and you are a wealth of knowledge. And we'll probably end it with that, Matthew.
I really like that one.
Yeah.
I had a piece of ginger right now, and then my eyes literally got watery on camera. I'm like, dude, I can't talk right now because I'm about to like cough.
Oh, I thought you were just getting emotional what I was saying.
I mean, that's pretty emotional. Like,
Okay. All right, guys, just to reword or not, just rewind here. The top 5 paying nursing professions that are going to happen in 2021 are going to be 1, registered nurse anesthetist, which is a CRNA, general nurse practitioner, clinical nurse specialist, psychiatric nurse practitioner, and a certified nurse midwife.
It's probably the quickest episode we have ever done.
Yeah. All right, guys, thank you for tuning in. Give us those 5 stars. Patreon is out. We're slowly updating it. Like I said, there's going to be 2 parts of it. There's going to be more of a nursing part where we summarize how our shifts went, and more of our personality side where we just act like a bunch of goofs and just have fun.
Yep. Site's coming out very, very soon. We have new shirt designs coming in. A lot of exciting stuff for couple nurses in 2021. Stay tuned. Thank you for supporting. See you guys next week.
See you guys. Peace.